Hello doctors, today we are going to discuss the thoracic trauma part 2. I have already made a video on thoracic trauma part 1. I will give the link of that video in my description. And major part of the thoracic trauma and immediate management and immediate life-threatening condition due to thoracic trauma are covered in that video. This is the part 2 and here we will see that what are the potential life-threatening causes of thoracic trauma. And this is the hidden 6 of deadly dozen 12 of thoracic trauma. So starting with the lung parenchymal injury. Lung parenchymal injury are mostly managed conservatively and via ICD. How to insert an ICD is already told in part 1. So ICD is generally placed in cases of lung parenchymal injury, and surgery is needed in cases of lung parenchymal injury if there is massive hemothorax or if there is massive air leak is present. Now, lung parenchymal injury, there may be peripheral injuries or it can be central injuries. If it is peripheral injury and there is persistent bleeding present, then we do stapled wedge resection. And if there is central injury, then we do pulmonary tracheotomy and we selectively ligate the bronchioles in cases of central injuries of the lung. Now, if there is major vascular or bronchial injuries, if there is major vascular injury, either we have to do lobectomy or we have to do pneumectomy in cases of bronchial or vascular major injuries. This is the first. Now, second is thoracic aortic disruption. Means aorta, the thoracic aorta is disrupted, and this is the common cause of sudden death after vehicle collision and fall from the height. And if there is thoracic aortic disruption, how will you clinically suspect in a patient? This is the most important point. That is, there will be gross systolic BP difference in both the arm, either in left or right arm. We have a person in the left arm and in the right arm. If we measure the systolic blood pressure, there will be a huge difference. Or if we measure the systolic blood pressure of the upper arm and we measure the systolic blood pressure of the lower limb, then there will be a major difference in between them. Then we have to suspect thoracic aortic injury. Or there will be wide pulse pressure and chest wall contusion may be seen. And in cases of chest x-ray, we can see widened mediastinum. Tracheal deviation will be there in the right side because the aorta, arch of aorta is over the left side, and when there is a contusion or disruption, because of that the trachea will be pushed towards the left side and there will be depression of the main bronchus, and apical pleural cap will be seen, and density in the left hemithorax will be seen, because if there is bleeding, the blood will get collected in the left side of the chest, as the arch of aorta and descending aorta is present over the left side. And this thoracic aortic disruption is confirmed by CT scan. Here we can see the x-ray. In the x-ray we can see this is the widened mediastinum. This is so wide. We can see in the chest x-ray widened mediastinum. And this trachea, if you observe here, this is the trachea, and trachea is pushed towards the right side. And if there is huge bleeding is present, we can see collection of blood in the left side of the thorax. So this will be seen in cases of aortic disruption, thoracic aortic disruption. And when we will suspect if there is first and secondary fracture, if there is bilateral clavicular fracture, if there is sternal fracture or scapular fracture, and the history will have a heavy impact injury of the patient. In 54 to 66% aortic isthmus is involved. Aortic isthmus is in between, the arch of aorta is mobile and there is the descending thoracic aorta. In between them, this is the isthmus, and this isthmus gets injured most commonly, that is 54 to 66% in cases of thoracic aortic disruption. Now this can be classified into 4 types. Grade 1 is there is only intimal tear is present. In grade 2 there will be hematoma. We can see hematoma here. In grade 3 there will be pseudoaneurysm present. This is a pseudoaneurysm present. And in grade 4 there will be total rupture of the thoracic aorta. So this is the grading classification of blunt thoracic aortic injury. You have to remember. Now, what is the management of the thoracic aorta injury? First, we have to manage that SBP should be less than 120 mm of Hg. Why? Because if we increase the SBP much more, then there will be much more bleeding and patient will worsen. Therefore, SBP should be less than 120 mm of Hg. Apart from that, we can use intra-aortic stent. Intra-aortic stent can be used, and if there is major bleeding, massive disruption of the aorta is present, then we have to repair the tear. Primary repair can be done, or we have to excise the segment. And we can use a graft here to repair this. And the graft which is more commonly used is Dacron. Remember this. Okay, this is asked many times. So Dacron graft is used. Now we have to see tracheobronchial injury third. The tracheobronchial injury, in cases of tracheobronchial injury, means there is a trachea and bronchioles. There is injury in either trachea or in the bronchus. So tracheobronchial injury, there will be severe surgical emphysema. This is the main thing. There will be severe surgical emphysema in cases of tracheobronchial injuries with respiratory compromise. Clinical feature will be patient will have hemoptysis, patient will cough out blood, there will be stridor and dysphagia. In 75 to 80%, if there is a penetrating trauma. Okay, if there is a penetrating trauma, 75 to 80%, it is because there is a penetration in the cervical trachea. In the cervical trachea, somebody has poked a knife or an object. Because of that, penetration have happened, because of that cervical injury have happened, and that is 75 to 80%. In cases of blunt injury, 75 to 80% is generally within 2.5 centimeter of the carina of the trachea. This is the carina of trachea, this is carina of trachea. There is 75 to 80% in cases of blunt injuries, and 40% of blunt injury generally happens towards the right bronchus. 2 centimeter of main right bronchus, there will be injury. These are the common sites of the tracheobronchial injury. Now, what are the investigation that we will do? In 3 investigations are majorly done. One is X-ray and CT scan. In X-ray and CT scan, we will see paratracheal air, deep cervical emphysema, and pneumomediastinum may be seen in cases of tracheobronchial injury. And if we do bronchoscopy, why? Because in bronchoscopy, we will exactly know the location of the tracheal injury or bronchial injury. Then we will also do the barium enema barium esophagogram, and barium swallow is done to rule out the esophageal injuries, because trachea and esophagus are closely lying to each other. If there is a tracheal injury, there will be high chances of the esophageal injury also. Now, this is in chest X-ray. Here we can see that there is a massive surgical emphysema present, and this will be seen in cases of tracheobronchial injury. In the patient will present to you like this. There will be massive surgical emphysema near the face, neck, and upper part of the chest, or lower or mid part of the chest will be majorly, there will be surgical emphysema initially. And there will be, when you press the skin of the patient, there will be crackling sound in present, by which you will be assured that this is a surgical emphysema. Now, what is the management? Management is ICD insertion, intercostal drain insertion is the major thing. Because why ICD is important? Because there is so much of air leakage. When we insert ICD, after that only the lung can expand. Apart from that, lung cannot expand if we do not put an ICD. So therefore ICD is inserted, and then a patient is intubated, and if there is a massive tracheal injury, then generally it is repaired. Now, how the tracheal injury is repaired? Here you can see the diagram. This is a trachea, and tracheal injury is repaired, and which suture is used? This is the PDS 30 suture. PDS 30 suture is used for tracheal injuries. Now we will have to see the myocardial injuries, means injury to the heart. It is associated when there is sternal injury or scapular fracture, or due to steering wheel, because steering wheel directly hits the sternum, which causes myocardial injuries. And now we have to see, in cases of myocardial injury, we have to see the ECG of the patient and 2D echo of the patient. And this is asked in MCQ, so I have marked this important. It is written in Sabiston and also in Bailey that cardiac enzyme does not correlate with the cardiac complication in cases of myocardial injury due to trauma. there is no, it doesn't, if there is a myocardial injury and you only see the cardiac enzymes are normal, it doesn't mean that patient doesn't have any myocardial injury. So remember this line, cardiac enzyme doesn't correlate with the cardiac complication in cases of trauma. Now in 2D echo, why we will do 2D echo? In 2D echo, we will see the regional wall mobility. If there is a regional wall mobility abnormality is present, we can see, and new onset pericardial effusion can also be seen in cases of myocardial injury, that can be seen in 2D echo. And there will be high risk of dysarrhythmia in patient of myocardial injury. And if there is a penetrating injury, there may be need for the surgical repair. Further details are not much required in this. Now if there is a diaphragm injury, which is very common, in my 3 years of MS general surgery as a postgraduate, I have already seen 7 diaphragmatic injury, and most commonly it is due to penetrating injury. If there is a blunt injury, then generally diaphragm tear is linear tear is present. But in cases of penetrating injury, it depends upon what object by which the patient was penetrated. The size and location depends on that. Now, generally management, we open the abdomen, then we do the diaphragmatic repair. Why? Because near the diaphragm we have the liver, we have the spleen. And in our next video trauma, I will make on abdominal injuries, and we will also read the grading of splenic and abdominal injuries. So over the right side we have the liver, and here we have the spleen. So therefore, if there is penetrating injury over the right side, the liver is generally also injured, and if there is penetrating injury over the left side, the spleen is generally also injured. So abdominal approach is used to repair the diaphragmatic injury in cases of trauma. So here we can see this is a diaphragmatic injury. We can see there is a diaphragmatic injury. If the diaphragmatic injury is small, generally we repair this. Primary repair is done, and which suture is used? We used Prolene 1 number Prolene suture. This is many times asked, and basically it should be known. Prolene 1 number suture is used, and interrupted sutures are taken. If the diaphragmatic injury is large enough, the primary repair is not possible, then you can use mesh. We can use mesh. And what kind of mesh you will use? We will use biological mesh, because biological mesh have less chances of infection. Because of that, we will use biological mesh. So Prolene 1 is used. Along with this, ICD is also inserted in the chest, and biological mesh causes less chances of infection in extensive tissue loss is present, if present in diaphragmatic injury. Now we will see emergency thoracic surgery. Emergency thoracic surgery is reserved for penetrating injury with signs of life. If there is present, then emergency thoracic surgery is required. Now first we have to read when emergency thoracic surgery is useless or futile. We do not need to do emergency thoracic surgery all the time. So mainly you have to remember these 3 points. Number 1, if there is an penetrating injury. Okay, if there is a penetrating injury and patient is already intubated, and after intubation you have started the CPR, and you have already given the CPR for more than 15 minutes, and still there is no regular rhythm, there is no use of emergency thoracic injury. And in cases of blunt thoracic trauma, endotracheal intubation is already done, and then CPR was also given for more than 10 minutes after endotracheal intubation, and then also there is no regular rhythm in the patient, then also there is no use of doing emergency thoracic surgery. And in cases of blunt trauma chest with no signs of life, there is no use of doing emergency thoracic surgery. So EDT means emergency department of thoracotomy. Like we have to call the CTVS surgeon, or we have to call the cardiothoracic surgeon. So what are the aim? What is the main aim? What we will do in cases of emergency thoracic surgery? Generally what are done? Number 1 is the cardiac massage is given. Cardiac massage is given in cardiovascular full patient. Control of hemorrhage is done. If you can see the bleeding point, then control of hemorrhage is done. From injury to the heart or lung is the present, we have to repair and control the hemorrhage. Control of intrathoracic hemorrhage from other sources apart from heart and lung. Then control of massive air leak if present in trachea, bronchioles, or from the lung parenchyma. Then we have to control the air leak, and we have to clamp the thoracic aorta, because I have already told the branches of the aorta. You can go into my playlist and watch the branches of the aorta, from what are the branches from ascending aorta, arch of aorta, and descending aorta. So we have this. If we are clamping the thoracic descending aorta, means the coronary arteries are the branches of the ascending aorta, means we are already giving blood supply to the heart. Carotid arteries and subclavian artery are the branches of the arch of aorta, means we are already giving blood supply to the brain. So we are clamping the thoracic aorta so that we can maintain blood supply to the heart and the brain of the patient. So these 5 points you have to remember, the aim of emergency department of thoracotomy, why we do emergency thoracic surgery. Number 1 is cardiac massage. Number 2 is control of hemorrhage from heart and lung, control of hemorrhage from other sources. If there is a massive air leak, we have to control that, and clamping of thoracic aorta is done. Now survival rate depends on the survival rate. If the blood pressure is more than 60 mm of Hg, the survival rate is 60%. Just remember 60 to 60. 60 mm of Hg, 60%. If it is more than 40, then the survival rate is still 30%. If it is less than 40 mm of Hg, SBP is less than 40 mm of Hg despite of resuscitation, then the chances of survival is only 3% in the patient. So remember this chart. Now, planned emergency thoracotomy. Generally, posterolateral thoracotomy is not used in emergency because of it is difficult to give position to the patient. Therefore, either we use 3 things. Either we use left anterolateral thoracotomy, or we use right anterolateral thoracotomy, or median sternotomy. Like depends on where the injury is. If we have to do left anterolateral thoracotomy, it is done in cases of injury to the left lung or left hilum of the lung. Over the left side, we also have the thoracic aorta. Then in cases of origin of left subclavian artery injury, then if there is injury over the left side of heart, and in cases of lower esophagus injury, then we use left anterolateral thoracotomy. And right anterolateral thoracotomy is done in right lung injury or right hilum of lung injury. If there is injury to the azygous vein, then superior vena cava injury, infracardiac IVC injury. If there is upper esophageal injury, we use the right side approach, and in the lower esophageal injury we use the left anterolateral approach. And if there is thoracic tracheal injury, we use the right anterolateral approach. And median sternotomy is done in anterior if there is injury to the anterior aspect of heart, and in cases of anterior mediastinum. If there is injury to the ascending aorta or injury to the arch of aorta, and injury to the pulmonary arteries and carina of trachea, then we use the median sternotomy approach. So these are the approaches, 3 approaches. Now we have to mainly know the major thing, which is also asked in many exams, and you will have a question. This is so important. What are the indications of operative treatment of thoracic injury? When we will call a CTVS surgeon and open the chest. Number 1, if I have already told this in previous part of thoracic injury, if there is initial tube insertion and there is drainage of more than 1000 ml of blood in cases of penetrating injury, and or more than 1500 ml of blood in cases of blunt trauma injury, then we will have to do thoracotomy. Number 2, if there is an ongoing bleeding, That is how much? More than 200 ml every hour for next 3 hours. Then we have to do thoracotomy. Number third, if there is caked hematoma, even after insertion of ICD, the hematoma, because of the formation of the hematoma, the blood is not coming out and lung is unable to expand. And caked hematoma, and we have already put 2 ICDs are already inserted, and still there is caked hematoma, then we have to do thoracotomy. Number 4, if there is great vessel injury, if there is great vessel injury, then endovascular repair in selected patient are also done. In patients of pericardial tamponade, we have to do thoracotomy. Now number 6, in cardiac herniation. So the number 6th point is the cardiac herniation for the indication of the operative treatment of the thoracic injury. Number 7th is massive air leak from injury to the lung parenchyma or trachea or main bronchus, left or right. And then number 8 is the tracheal or main stem bronchial injury. Number 9 is open pneumothorax. Number 10 is esophageal perforation, and number 11 is air embolism. And the most common complication for thoracic trauma is empyema. In empyema, we manage empyema by putting ICD, and generally ICD is directed towards the diaphragm in cases of empyema, as empyema is thick. So this is the part 2 of trauma chapter for thoracic injury. We will next continue with the abdominal injuries in trauma for my next session. Thank you for watching, guys, and please do like, share and subscribe to this channel so that I can make more free videos for medical students. Thank you, guys.